You're the guy people call when they need a helping hand, moving furniture, unloading a truck. But lately, your shoulder's been acting up, and you're the one who's calling for help. And that's the moment you realize you can no longer shoulder the load.
The Joint and Spine Center is Cincinnati's leading destination for orthopedic care with a range of surgical and non-surgical treatments. So when a moment has the power to change the rest of your life, go to the one place with the power to change it for the better, the Christ Hospital Health Network. This changes everything.
The Pound This Podcast is brought to you by the Christ Hospital Health Network. This is the Pound This Podcast, episode 572, How Sleep Impacts Weight Loss and How the Pandemic Has Impacted Your Sleep with Dr. K.
I want to lose weight, but I don't know how to get started.
What should I meal prep every week?
How do I get those sweet booty gains?
Inspiration for your healthy lifestyle. The Pound This Podcast with Amanda Valentine.
Thank you so much for listening to the Pound This Podcast. I am Amanda Valentine. My guest is Dr. K from the Christ Hospital Health Network. We're going to talk all about sleep. How are you, Dr. K?
I'm good. How are you, Amanda?
I'm great.
Thanks for having me.
Yes, thank you so much for being here. I mean, when we're going to talk about the topic of sleep, I mean, I have a whole list of just notes upon notes of like stuff that I wanted to make sure that we talked about because, I mean, there's a lot to cover. But before we get kind of digging into my questions, I just wanted to learn about, you, what's your background? How long have you been at Christ Hospital? What do you specialize in? I mean, just give me your whole biography.
Sure. Yeah, I'm Dr. Kanagarajan. I go by Dr. K, like you said. And I did my medical training in India. And I came to U.S. In 1999. In New York, I did my residency in internal medicine. Then my training, specialization in pulmonary and critical care. I'm basically a pulmonologist by training in Manhattan. And then for my first job, I came in 2006 to Cincinnati. I liked the Christ Hospital, and I joined the practice as a pulmonologist. And from there, I learned that sleep and breathing problems exist together a lot. A lot of my pulmonary patients had problems, mostly breathing at nights, the sleep apnea you might have heard, which is such a common disorder. So my passion kind of evolved into sleep. So I now, basically my focus predominantly in sleep. I do some pulmonary practice also. I've been with Christ Hospital for the last 14 years. I'm the medical director for the sleep labs at the Christ Hospital. We have a 10-bed lab in 2 different locations at Auburn and Red Bank. And then we have multiple clinics on top of the sleep lab where the sleep study happens. We are kind of all over in the tri-state between myself and another physician, my partner, Dr. Dharma. And then we have 3 other nurse practitioners in our team. We kind of cover from Kentucky. Right now, today, I'm at Mason location for the hospital. So we kind of cover all the locations, and I kind of oversee the whole program.
So what does your day-to-day kind of look like? Like, what kind of patients are you seeing on a daily basis?
So mostly I start my day in the office. We see a lot of patients with sleep apnea. I would say probably 75% of my patient population is sleep apnea, which is stopping breathing at nights, and we treat them with CPAP and other kinds of treatment, which we can talk as we go along. What are the other modalities available? And then I do have maybe another 10-15% of patients that have insomnia, and especially with the COVID now, I'm sure you must be getting those calls about almost every patient that I speak with nowadays since the pandemic started have insomnia related to everything that's going on with the stress and anxiety that's out there. And narcolepsy, restless leg is some of the other kind of patients that I see. And then I'll be looking at sleep studies that are done at overnight by the technicians when the patients to diagnose the problems. So I'll be reviewing the sleep studies and also administrative work, keeping an eye on the technicians that does the sleep studies, making protocols, policies, And with COVID, we changed a lot, like doing COVID testing before patients come into the lab. And also oversee, we do a lot of home sleep testing from the office to diagnose sleep problems. So it's kind of a mix of a lot of things, but mostly patient care. I would say 80%.
Okay. So I want to get to kind of what's been happening with sleep with COVID here in a second, but I do want to ask you about just like a healthy sleep routine and sleep and weight loss, because if you look into any sort of weight loss articles and they're like, your best tips, your best practices, other than, eat healthy foods and move your body, having a good night's sleep, it plays such an important role in losing weight and being healthy. Like what are your thoughts on that? Like what's sleep's role in that?
Yeah, sure. So yeah, definitely a good night's sleep has been linked with maintaining appropriate weight. If you don't get enough sleep, has been associated with weight gain. And also, too much sleep also is associated with weight gain. It's kind of a U-shaped curve when you look at sleep and weight loss. So too little sleep make you gain weight. Too much sleep make you gain weight. So the ideal kind of the sleep, I would say around, you aim for 6 to 7 hours at least of sleep is associated with a healthy weight. And it's very interesting to know that the sleep deprivation itself causes a lot of hormonal changes in the body. The two main hormones that I would like to point out would be leptin and ghrelin. Ghrelin is a hormone that make you gain weight. Leptin kind of keeps you lean. So during sleep deprivation, or if you're if a night's sleep is completely disrupted because of all kind of issues like sleep apnea, insomnia, restless legs, can increase the ghrelin and make you gain weight. And leptin is kind of an anti-ghrelin hormone that kind of pops up in your body more when you have a healthy sleep. So it is a true statement that sleep and weight is completely related. And another thing I want to point out to you would be even the timing of the diet. We always talk about diet. I saw in your other podcasts, I heard you have all these various diets that people try. Simple maintaining the diet along with your circadian rhythm. Even if you have a same kind of calories when you ingest, Amanda, the maintaining that rhythm of the timing of the food intake will affect your weight. So for example, if you maintain your diet intake between, say, 8 to 5, not eating too late, at the same time, not having food like 4 or 5 o'clock in the morning, that itself, maintaining that same calories in the same kind of timing will cause more weight loss than eating at odd times.
Okay. That's interesting.
You follow what I mean?
So
yeah.
Does that affect anybody that's working like odd shifts, like a second shift or a third shift or overnights? Or is it just constantly keeping a same window, or does it matter what time of day or if the sun's up or not?
It is, unfortunately, yes, going with the circadian rhythm, what time the sun is up, and when they did look into the studies, cueing, the sunlight cues your body to release all these hormones. So when you do a shift work, actually you are going against the circadian rhythm. And it not only disrupts the sleep, it does cause weight issues. And you might have seen or heard people working night shift, munch on these the junk food that we crave for. So those are all natural body craving for it, rather than, we are doing it as a habit.
Okay. So have you noticed an uptick any health issues or sleep issues because of COVID, because it feels like a lot of people have either gone into working at home and changing their rhythms and how they sleep and what they're consuming and being on screens and Zoom meetings and stuff like that, or because they're frontline workers or essential workers and they've had to like double shifts and work extra. Like, is this just kind of in the past 6 months, is this just really thrown everybody off?
Yes, absolutely. Yes, I have every patient that I talk to nowadays have something related to COVID-19 in terms of their sleep issues, weight issues. Definitely, I'm hearing a lot more patients complain about the weight gain during this time. I don't think it's just because we are staying home doing nothing. I think it's because of the circadian rhythm. You're losing almost everything that we do now. We are going against the sunlight. Quarantine, school closure, working from home, everything that we do now it's against the circadian rhythm for most of the people. The essential workers like myself are lucky that we are still maintaining the same rhythm. I still come to the office in the morning and go home in the evening. So it's not a problem for me, but I do hear that a lot with the patients now, which I strongly think it's because of going against the circadian rhythm, the sunlight and stuff like that.
So how do we go about fixing that? Is it just getting used to a new rhythm?
Yeah, I would say try to maintain as much as possible close to natural rhythm. If you are working from home, at least expose yourself to the sunlight in the morning. If you maybe walk in the neighborhood or in the park, maintaining the social distancing, of course, would be a good idea. And keeping maybe your house lit up more instead of staying in a dark room during the daytime, staying in a well-lit room might also help. Light is a big cue. We call it Zeitgeber. I love that word. It's a German origin word. Zeitgeber is like the sunlight is a major Zeitgeber, which cues your brain to be awake. We are awake not just because we slept enough, but also the sunlight cues us. That's why we wake up in the morning around 7, 8 o'clock when the light is up, and then we tend to fall asleep in the night because the sunlight goes away. So it's a very important role it plays. So I would say keep as much as possible if you're working from home, well lit, and at the same time, the opposite, when evening comes, make sure that before bedtime, the house is as much as possible dark, that you want to maintain, stay away from the electronics that emits this blue light closer to the bedtime. I would say at least an hour and a half before, turn it off. Keep the same kind of work schedule that you have. I've been telling that I can't stress this enough to the patients. When you work from home, you work from start work at 11 o'clock, and then maybe you carry the work till 11 o'clock in the evening, at night, encroaching on your bedtime, because you can do whatever and whenever you want. I would probably recommend maintaining the same schedule that you had when you are in the workplace, if possible. But of course, with school closure, with the kids, you can juggle only so much. But as much as possible, I would say keep the same kind of schedule and try to minimize the light exposure towards the bedtime, and then have as much as possible the light exposure during the daytime.
So speaking of electronics, do those blue blocker glasses do anything?
Yes, there are some data. The orange glass, when you cover it, it reduces the blue light. So the blue light is the one that suppresses the melatonin. So melatonin is a hormone that secretes from the brain. The pineal gland, a tiny peanut-sized gland in our brain that secretes melatonin. Like I said, when the sun goes down, and when your eyes don't see the sunlight, the brain gets a cue that it's time to secrete the melatonin, and the melatonin is the one that naturally puts you to sleep. So the blue light from your TV, iPad, iPhones, everything that emits blue light blocks this melatonin secretion, and that's why you can't fall asleep. When you look at the iPhone all night before bedtime, it does affect and you can't fall asleep. So the orange glasses, it theoretically blocks those blue light hitting your brain through the retina in your eyes, does help some. But my main advice would be a electronic curfew 90 minutes before your bedtime. No TV, no gadgets.
Yeah. Well, speaking of melatonin, then, is it safe to take a melatonin supplement? I mean, been seeing more and more stuff, including, I think, Pepsi just released a new soda that has melatonin in it for sleep. I mean,
yes, the drift well.
Yeah, I mean, is that stuff useful, or is that something you should stay away from?
I thought the Driftwell brand that they said it's L-theanine. That's another synthetic amino acid that helps with the sleep. I'm not sure if that has melatonin in it. At least I didn't read it when I saw that Pepsi kind of commercial or infomercial. It has L-theanine in it. Yes. So melatonin I would say it's generally considered safe, and it's not a habit-forming drug. So I like it, but it may not work it depends on what you're taking it for. I would highly recommend melatonin for shift work. We talked about the night shift. So you're going against your circadian rhythm. So when you come back home, the sun is up, your melatonin in the brain is not secreting, and you're not able to fall asleep when you come back from work. So that melatonin supplement does work great in that situation. And jet lag is another, when you travel continent or different time zones when you travel, and melatonin would be a great supplement to take, because where you're traveling from, you're traveling faster than the time zone, and you're there, and your back home time is not synced with your internal clock, and the melatonin definitely works. Generally for insomnia, when I looked at the studies, melatonin had maybe 7 to 8 minutes extra sleep time it gives. But again, you are balancing that with, I have patients that complain next day they are groggy when they take melatonin. So the dosage and timing is important. So I would say I always tell patients to take, not more than 3 to 5 milligrams tops if you are taking it for insomnia, and about 90 minutes before your bedtime. And if it works, it works. If it doesn't, it doesn't. Like I said, for insomnia, melatonin is okay for some patients, but not such a great drug for most of the patients, other than shift work and the jet lag.
Well, speaking of insomnia, I mean, what's the definition of that? How do you know that you have insomnia versus just having some sleep issues because of life changes?
So we define insomnia like a chronic insomnia. Everybody goes through, I'm sure. I would say most of the people have an episode of insomnia in their life, like you said, like life changes, death in the family or an anxiety-provoking situation. That's normal. You go through the acute situation, it gets better, then you sleep back to normal. But if you're having difficulty in sleep for more than 3 months continuously, then we label them as a chronic insomnia. So chronic insomnia, my first recommendation, my first line of therapy is not medications. I would highly recommend what I preach and practice, cognitive behavioral therapy for insomnia. So it's basically telling patients to do some behavior changes. And we also add a thinking component about overall expectation regarding sleep. Sometimes it might be just a thing that most of my patients read about, like, oh, I need to sleep 8 to 9 hours, that I read in some blog or web page, and you just kind of worry about this a lot because I'm not sleeping 8 to 9 hours. So just talking about it and changing the thinking component, it's what we call cognitive behavioral therapy. So you set some expectations, say, okay, if you're sleeping 6.5 hours or 7 hours, as long as you're getting your core sleep and you're functioning next day, okay, you're coming back to work and you're conducting your podcast like you do now, but you slept only, say, 6.5 hours last night, but you're next day not feeling fatigued, tired. That's normal. So recognizing that. So that's cognitive behavioral therapy, educating and rethinking. And then the sleep hygiene we talked about, like no gadgets. So it involves a lot of education, teaching, and that works, I would say 60 to 70% of the time without any medications, and setting up the expectations and setting up a fixed bedtime and wake up time. Especially once you retire, the bedtime goes away, wake up time goes away. And the COVID we talked about, there is no fixed bedtime, wake up time. Stick to the schedule. It's a major component. And keeping the bedroom, cool, dark. Definitely the cooler the bedroom. There are studies out there that pointed out that cooler the bedroom, the more you sleep, which is much better than any medications out there. Like I pointed out, melatonin gives you only 7-8 minutes of extra sleep, and most of the branded pharma medications gives you 20 or 30 minutes extra sleep tops. And you can achieve that by just modifying your behavior. And when they did studies on cognitive behavioral therapy, patients did fairly well in the long run compared to any medications out there. So that's my first line treatment, cognitive behavioral therapy. We used to send patients to psychologists to do cognitive behavioral therapy. Now I do that as much as possible in my office, as well as I give patients, now you can do the cognitive behavioral therapy online. CBTI can be done online. It's almost like seeing a psychologist. You go through sessions. There are many programs out there that you can do online. So I do recommend those kind of treatment for insomnia. But if it's acute one, yes, you have a death in the family, you want to get through an anxiety situation that's going on, a short-term medication during that to get over the crisis, then there is a role for medications. But for chronic insomnia, I think my first line therapy would be cognitive behavioral therapy.
For somebody that has chronic insomnia and they've just kind of been self-medicating, getting their Z-Quills and stuff like that, just kind of the over-the-counter sleep medications, are they doing some more long-term damage to themselves by doing that to try to get through it?
Yeah, most of the over-the-counter medications are okay, are safe in the short run, yes. Like the Z-Quil and Benadryl that you pointed out, most of them are what we call antihistamines and anticholinergic drug. So acetylcholine and histamine are two of the wake-promoting neurotransmitters, the chemicals in your brain. And so these over-the-counter prescriptions are kind of block those neurotransmitters in the brain, and that's why you feel drowsy. The anticholinergic and antihistamines are okay, but there are some studies out there where anticholinergic can cause, memory problems, memory issues. Especially acetylcholine is a neurotransmitter that you need that for your memory. So memory issues can be a problem when you use it for a very long time. But for short term, yes, like I said, for acute insomnia, you want to get through a crisis, a stress in the job, you lost somebody in the family. For short term, yes. But I wouldn't recommend any of those as a long-term solution.
So are insomnia and sleep apnea ever connected to each other?
Yes, sleep apnea can present as insomnia, especially in women. But when I see so sleep apnea is more common in men. So in men, the main complaint is sleepiness. They come to me, either they are complaining of sleepiness or they are sleeping too good. They come to me and say, I don't have any sleep problem. I sleep good for 11, 12 hours a night and a couple hours during the day. I say that's not normal. Only my wife complained because I snore like a freight train. So that's a clue that, yes, then I have to point out that sleeping 11 to 12 hours a night is not normal. So that, so in men, it kind of present a little bit different. Whereas in women, I hear more complaints like more insomnia. I don't know, I wake up at 3 o'clock in the morning. I don't know why I'm waking up. And when you dig detail, then you get, the snoring history, and snoring goes with sleep apnea. So yes, it can present as insomnia, but the most common presentation is excessive daytime sleepiness during the day. The sleep apnea present as.
So what causes sleep apnea?
So sleep apnea happens because we have this airway behind back of our throat. During night, it collapses completely in sleep apnea. So the airway has to remain open so that your body gets the oxygen in, the brain gets the oxygen that it needs during the sleep. So when your airway collapses behind the throat, so you stop breathing. So when the airway is narrowed and the air moving through the narrowed pathway makes sound, is snoring. But if the airflow completely stops, then your chest doesn't move, everything gets stuck behind the throat. So it collapses like a flat tire in the back of your throat, and the air doesn't get down to your lungs. So that's when the spouse notice, oh my gosh, he's snoring, and then suddenly there is a pause because and the air is not moving and your chest is not moving. So your oxygen drops, your brain have these arousals. Sometimes we wake up gasping. That means your oxygen is really low during sleep. But if you have subtle low oxygen episode, it just arouse the brain, but not wake up. So you wake up feeling fatigued, tired, sleepy, because you're not in the deep sleep that you need, the stage 3 and 4 sleep. You're constantly in the stage 1 sleep because of the stop breathing. What causes it? The most common cause is obesity, and that's what causes the tissues in the back of your throat to be crowded and narrowed, and it makes you collapse faster. So the more weight gain you have in the middle, especially the middle part of the body, where the airway is behind the throat, the obesity is a common risk factor. There are 20-25% of sleep apnea can happen in thin persons also. So anatomically, like an overbite, if your mouth is too small or crowded because of the teeth, and the jaw is kind of pushed backwards, so the airway is narrowed because of that. And those are the kind of main common causes of sleep apnea. I would say obesity is a top common cause.
Okay, so I don't know. I mean, not for you to give a diagnosis over this podcast, but is this a form of sleep apnea? So my husband is not obese. He does not snore, but he will wake up every 2 to 3 hours, and he can fall back asleep immediately. He falls asleep immediately every time. But we've been together 16 years, and he's been that way the whole time. He'll only sleep 2 hours at a time and then wake up and then fall back asleep again. What is that?
Yeah, so there could be many reasons. Again, sleep apnea, when I hear that from the spouse, so it's when you say snoring and stop breathing is such a spouse-dependent factor, you don't know 3 o'clock when you are sleeping really deep what happens.
That's
Why
true.
is he waking up?
Yeah.
So still it could be, but again, the other reasons that why patients wake up, there are so many other causes why you can have awakening at night. Restless leg is one. I don't know if he kicks a lot during the bedtime. When you wake up, you find the sheets are all messy on that side. That person was definitely restless. So restless leg is another common thing that I see that can cause nighttime awakening. And if he's waking up at night and pee a lot, that could be also a sign of sleep apnea. One of the common symptoms that I hear, waking up at night, I wake up 3-4 times to pee.
He does do that.
So that's another subtle sign that could be cluing into sleep apnea, but that doesn't exclude that he might, again, I'm not trying to diagnose a problem here. Other problems like bladder problems are, it could be something not totally, it could be related to some other system like bladder, kidney problems. If it's women, frequent awakening during menopause, like hot flashes can be waking you up at night. Like I said, you need a the cooler the temperature, you get a better uninterrupted sleep at night. The body actually cools down by 2 to 3 degrees before bedtime. Again, the sunlight is a clue. When the sun goes down, melatonin comes up, body temperature plummets 2 to 3 degrees, that make the brain to fall asleep. So all these things has to be kind of synchronized. It's a complex, reaction between the outside Zeitgeber, the light, and the inside neurotransmitter and chemicals. Any disruption in this pathway can wake you up in the middle of the night.
Okay.
And sleep apnea, restless leg, medications you are taking could be the problem. Some of the medications, like over the counter, like we talked about, the nasal congestion. People take. Sometimes I point out that I'm always congested, so I take Afrin during the day. Again, that's a stimulant. Caffeine intake. You might be just arousing. We always say that don't drink caffeine after 5 o'clock, but I would say even some of my patients are so sensitive, even drinking caffeine after 12 noon or 11 o'clock in the morning, their brain awake during the night, causing disruptive sleep. Any prescription pills, so many steroids, beta blockers, we take it for granted, has that subtle warning that 1 to 2% insomnia could be a reason why your brain is waking up in the middle of the night. Asthma inhalers can also do that. Alcohol consumption. People think that, I always hear that, I drink 2 glasses of wine, I just mellow me into sleep. Yes, alcohol put you to sleep, but once you pee out that alcohol, once it comes out of the system, it wakes the brain up. That 3 o'clock awakening in the morning could be related to that 2 shots that you had the night before. That's another common cause that I hear from patients, that they're waking up at 3, 4 o'clock in the morning, not knowing the reason. And the reason is just you cut the alcohol down or move it, before your bedtime, 4 or 5 hours before the bedtime. So it could be a lot of things why somebody can be waking up frequently, not just sleep apnea.
So is it once you get past the point of kind of going down that checklist, is that the point that you're like, okay, I need to go to the doctor, I need to go to the hospital? I mean, usually what's the turning point where somebody comes, sees you?
Yes. So I would say the clear warning signs, loud snoring that rattles the home. It's, I would say, yes, that could be a factor that you might be dealing with, something more than snoring. Like I said, snoring and sleep apnea goes together side by side. So loud snoring, feeling fatigued, tired during the day, and inability to sleep, like I pointed out, more than 3 months, chronic insomnia, the restless leg symptoms that I pointed out, excessive daytime sleepiness, narcolepsy is another thing. People think that, they watch the movies and think that narcolepsy means like, you're talking to somebody and then you could falling asleep in the middle of the sentence. Not necessarily like that. That's type 1 narcolepsy. There are 2 different narcolepsy. Type 2 narcolepsy can be very subtle. And one of the symptoms of type 2 narcolepsy is not only daytime sleepiness, but not having restful sleep at night. It could be that also. So excessive daytime sleepiness is something that I would highly consider a red flag sign. Waking up at night like 2 to 3 times to pee, like we talked about. If it is not a problem with your bladder, kidney, urethra, that could be a sign that you might be dealing with underlying problems like sleep apnea. And very restless sleep, like I was pointing out, any messed up sheets in the morning, leg kicking a lot. I have had so many times the spousal complaints. He kicks all night, and then we do the sleep study. We see with the monitor that with the electrodes, looking at the leg movements, they are running marathon at nights. But brain is still sleeping, not in the deep sleep that you need. So restless leg is another kind of a red flag sign that I would say, come and talk to your doctor. Fatigue, sleepiness, frequent urination, morning headache, early morning headache. I slept good, but I'm waking up with a headache in the morning. That could be a sign that brain was deprived of oxygen at night, causing morning headache. And those are probably, I would say, a few red flag signs that I would say talk to your doctor.
Okay. Well, on the topic of narcolepsy, my mom has narcolepsy, and just forever, she would just fall asleep watching TV and just kind of, then she just thought that she was she's a healthcare worker, so she was on her feet all day and would come home and watch TV and fall asleep. For me as a teenager, I thought it was awesome because I could sneak in the house and she didn't know.
Yeah.
But she didn't get diagnosed until she fell asleep behind the wheel and had a car accident. And then she started going into sleep studies, and then she was diagnosed with narcolepsy because, yeah, like you said, not in the movies. She doesn't talk to you and fall asleep. But if she kind of sits down to watch a TV show or a movie, you get about 20 minutes in and she's out unless she's taking her medication.
Right. Yeah. So narcolepsy is a fascinating diagnosis, obviously not for the patient. There are two kinds of narcolepsy. Type 1 that you see in the movies, that they are, you're in the middle of the sentence, you're falling asleep. They have this, what we call cataplectic attack. Like you laugh out loud and you lose your muscle tone and you fall asleep. So basically narcolepsy happens because of a deficiency in a neurotransmitter called hypocretin in our brain. So when you have the hypocretin keeps you awake and keep you going. When you have a deficiency of the hypocretin, then people tend to fall asleep a lot. And that's when you diagnose narcolepsy. And you need the hypocretin deficiency also causes these dream coming in random times, like when you fall asleep and nap and then you're waking up, that 5-minute nap, a lot of dreams. So those are the things that we look for in the sleep study. In the nap study, are you falling asleep too quick and having a lot of dreams in that nap? So it's kind of a pentered, we say, sleepiness, having a lot of dreams during the nap, sleep paralysis. You might have heard that. You wake up and sleep paralysis can happen once or twice, which can be normal. But if it happens frequently, that could be a sign of narcolepsy. You wake up and feel like you're awake, but you can't move the whole body. You feel like it's all paralyzed, and then you push yourself to move. It's a scary thing that these patients describe. That could be a sign that you might be dealing with narcolepsy. And the type 2 narcolepsy could be very subtle. All I hear is like, how you pointed out with your mom, they can't watch a movie. They just fall asleep while 10, 15 minutes into a movie, and not necessarily having all these, paralytic attack that I described. And when you keep asking the questions, how sleepy they are. So I give them the questionnaire to do, to assess their sleepiness, how sleepy they are. So it gives you all these scenarios. When you watch a movie, what are the chances of you're dozing off? When you're driving, are you falling asleep? So we kind of get an assessment about how sleepy they are, and then ask all these other questions. Do you have this sleep paralysis? Do you have this cataplexy episode where you laugh out loud and then you lose your muscle tone? And it can be very subtle. Sometimes I've seen patients describe like, I just feel little numbness in the back of my neck. That was one of my patients complained, along with excessive daytime sleepiness. But like you said, you're right. It's more commonly diagnosed when you're young, and but it can go on. My first narcolepsy patient I diagnosed when she was like 62, because she complained about these sleepiness. She was given various different diagnoses, ADD. You're just not able to focus because you have ADD. Which I don't know whether adult onset ADD is a real factor or not, but I do see that patients get that diagnosis, and the treatment is anyway stimulants, so they keep going like that, and then you explore in detail. It's a subtle form of narcolepsy. And I was fascinated to learn when I was doing the sleep medicine that narcolepsy can be as common as a multiple sclerosis. The prevalence is as common as MS. People talk about MS a lot. We all know MS is, at least everybody knows someone that has MS, but I don't think not everyone can relate that somebody have narcolepsy. That's because probably it's very underdiagnosed.
On a totally different topic, how important is our bed to our sleep?
Very important. Having a nice, comfortable bed is really important. And now they have all these various beds that change to various positions. It can help. I do have patients, especially with sleep apnea, we do recommend positional therapy. If you have a mild sleep apnea, especially on your back, you can avoid that by elevating the head up, your bed to a certain positions. The snoring goes away when you kind of sleep as long as you're comfortable. So having a comfortable bed is really important.
Is there any truth to like you need a new mattress every 7 years or whatever? Or is that just marketing?
No, that's just marketing.
Okay. That's good to know because that's expensive.
Yeah. Yes. I don't think that's necessary.
So if anybody had any more questions or they're, how they're listening to this podcast and they're kind of hitting some of these markers of like, oh, that's me, I should probably look into this. Is there the best way to find you at the hospital?
Yes. The Christ Hospital website has all our information, www.thechristhospital.com/sleep. If you put sleep medicine, Christ Hospital takes you to our centers. Like I said, we have the sleep centers where we do the sleep studies, but we have multiple offices in various locations. So you will find all the information on the website, and including the phone numbers and the contact numbers for our office. It's all in there in the Christ Hospital website.
Awesome. Well, this has been so informative and helpful, and I can't thank you enough for your time, Dr. K. Thank you so much.
You're welcome, Amanda. Nice talking to you.
You too.
For info on health coaching and more, go to AmandaValentineBites.com.